Okay, on to chapter 11 and 12. This should go fairly quickly. Unfortunately, this is just a lot of memorization for you, and also a lot of completing the spreadsheet that I gave you. So, one thing you might want to spend time on, or I would encourage you spending time on, is understanding how muscles are named. That will help you as you're learning because the words will be a little less foreign to you. This table in the book 11.1 is absolutely fantastic. Um, and there will be, I guarantee you, a couple of questions on the exam that require you to know um, a few words, things like polysis, uh, brevis longus, etc. So this is just an overview of the muscular system, and essentially everything on here you guys will be responsible for, either in lab or on the exam in the lecture section. Uh, so starting with facial expression, I'm not going to go through all these. What you're going to want to do for these is be able to identify them. So if there was an arrow pointed to this muscle, you could say it's frontalis, or if there was an arrow pointed to this muscle, you could say it's orbicularis oculi, etc. Anything bolded is going to be important, and it should be on the spreadsheet that I gave you, in the head and neck muscles. Um, and you're going to want to understand what they're doing. So zygomaticus major and minor, they raise the corners of the mouth, for example. Um, Going down, again, just identification, understanding what they do. You can start to see some of the muscles of mastication here. Uh, I'll talk about that in a second. Oh, and I would note that I took corrugator's supercilii off of the list that you have. So there are some things that are bolded here that are not on your list. I took off depressor labii, anguli. I'm pretty sure I took mentalis off and rhizoris, I believe. Just a nice view of a cadaver. If you progress in your anatomy training beyond this course, you will likely be identifying muscles on a cadaver, and it's a little bit more difficult because they're not as cleanly drawn or colored or tagged as they are in cartoons. So I won't show you any cadaver images on the exam, but just be aware that at some point you will be identifying them. So muscles of the book divides the muscles a little bit different than I do, but you can categorize them however you're comfortable. Chewing and swallowing is going to be mostly tongue muscles, so it's going to be mostly glossus muscles. I believe there's 8, 4 intrinsic, 4 extrinsic, um, and just understanding what they do. Hyoglossus will pull the tongue down, styloglossus pulls it up and back, etc. Not worried about what they do during, as you're eating, which muscles are working. I'm not going to ask any questions like that. Just be able to identify these as tongue muscles. Muscles of mastication, there are 4 of them. This is the 4th or 5th time that we've talked about muscles of mastication, so you should be ready to see these. You will need to know the origins and insertions of these, although they are pretty straightforward. Temporalis and the masseter are the 2 major muscles of mastication, and then the medial pterygoid and the lateral pterygoid are what kind of lateral pterygoid is going to move your mandible sideways as you chew. Medial pterygoid is going to help elevate it and also move it sideways. And remember that medial and lateral pterygoid are actually both attached to the lateral pterygoid plate. They're not attached to the medial pterygoid plate. Recall that this is the sphenoid. It's a little odd that they're not, so that's odd things are good to keep in mind in certain cases. And then we move on to the muscles that are typically connected to the hyoid. Again, simple memorization and understanding kind of generally what they're doing. I do like the digastric just because it's unique in its anterior and posterior. It's one muscle which passes through the hyoid, but it is still one muscle. Again, just memorization on this. And then neck muscles, sternocleidomastoid is really is the big um, is the big one here physically and just as a landmark. So Again, a lot of these you saw on the previous slide with connected to the hyoid bone. One thing that's a little odd is that muscles that you think should be back muscles end up not being back muscles. So trapezius, even though it's essentially, a huge muscle on your back, what it's doing is actually extending the neck. So we talk about it as a head and neck muscle. And I know that gets confusing, but it's just, I guess, the way that anatomists do it. Muscles of respiration, there's 4 of them listed in the book. The main one, of course, is the diaphragm. And then you get the intercostals. Keep in mind that the intercostals are accessory muscles and that you'll see them being used when people are having problems with their diaphragm, or in diseases like emphysema where people are trying to inhale or having problems actually expanding their lungs. Those accessory muscles are going to take over and help do that. Muscles of the abdominal wall, so there's 4 of them. The rectus abdominis is what you classically think of as your abdominal muscle, but remember there's external, internal abdominal obliques, and there's a transverse abdominal. We will see an inguinal hernia again at the end, and we'll want to remember that the external abdominal oblique is kind of what the fascia from that is, or the aponeurosis, which connects to the pubic symphysis, is kind of what causes that problem. And here's just a different view of the abdominal muscles. And you can see on here you have things like pectoralis major, the deltoid. All these should be starting to look a little bit more familiar now that we've covered both abdominal muscles and the extremities as well. On the back, so there's 4 back muscles, which I screwed up really well the first time we went over this. There's multifidus, quadratus lumborum, and then there's the semispinalis muscles. I'm not too worried about these 3. What I do want you to know is the 3 erector spinae muscles. So it's really one muscle, or at least it's listed that way, erector spinae, but the 3 subdivisions, iliocostalis, longissimus, and spinalis, it's important to know those 3. And the mnemonic is obvious at this point. I like spaghetti from lateral to medial. We went through the muscles of the pelvic floor fairly quickly. There's 7 or 8 of them listed in the book. We will return to these when we talk about male and female reproduction. But a couple things that I want to note, even though they show you a male here, remember that males and females have bulbospongiosis, and it serves essentially the same function to help maintain an erection of either the penis or the clitoris, and also help with urination. And then also note the transverse perineal here. So the perineal body is kind of an attachment point for all the muscles of the pelvic floor. So you try to protect it. And if you look at the female cartoon here, you're going to see there's a deep transverse perineal, and there's also the perineal body. One thing that happens during childbirth is that you can get tearing in this area, and you try to minimize the damage that tearing does. Really what you're trying to do is minimize the damage to the perineal body, and you do that through a procedure called an episiotomy, which is essentially a cut that's made typically at a diagonal angle. And what can happen actually is that cut will go through bulbospongiosis and or the perineal muscle, and that does cause issues. We'll return to this at the end of the semester, but I just want you to know that these muscles, they're worth learning because you're going to hear them again. And then remember that compressor urethrae is a muscle that is present in females but not in males. And then the levator ani, this is really the big muscle of the pelvic floor. It kind of holds everything up, if you will. And its main function, besides holding things, is that it relaxes during a bowel movement to allow the feces to pass through. So I know this will be a shock to most of you, but yes, everyone poos. So, and levator ani is really a big player in that. So inguinal hernias, this can happen in males and females. It's just a little bit more common in males. So the small intestine here is actually passing through the external inguinal ring and going into the scrotum here. And remember that the food is still passing through here, so digestion is still occurring in this hernia. This can be blocked, it can necrose, and I told you in class that there was an image in the New England Journal of Medicine recently that that showed a quite serious inguinal hernia. If you're a little squeamish, you might want to not look at this, but you can get an idea of how big these can get. The 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 demarcation between the scrotum and the abdomen here is kind of lost. But this is a right inguinal hernia, and the case report is interesting. 67-year-old who's had this hernia for 25 years. He's actually refused treatment several times. It's 55 centimeters by 30 centimeters, which is impressive. And you would think that you'd want to repair it, but apparently they were worried about bleeding and other complications. So they treated him essentially with a high fiber diet and laxatives to try to clean everything out, if you will. And unfortunately, this patient was lost to follow-up, which happens a lot. Okay, chapter 12, which is the upper and lower extremities. Remember that when you get to the upper and lower extremities, you should be thinking about these in terms of compartments. In the upper limbs, you're going to have an anterior and posterior compartment. In the lower limbs, you're going to have more compartments. You're going to have anterior, posterior, medial, and lateral. And if you look at the spreadsheet that I sent you, these are kind of grouped kind of that way. And if you'd like to change this, you can. But if you go to the upper extremity muscles, and you look in the upper arm, you're going to see the posterior and anterior differentiation. And maybe it's a little bit more obvious here, especially when you look at the leg. Anterior, posterior, and lateral. So that's a good way to start to kind of categorize these. And then here's just an image of the leg. Again, a couple of you have mentioned, changing the color of your spreadsheet to kind of go with these images, and I would strongly recommend that. So really quickly, we're just going to run through these. The muscles acting on the shoulder. If you look at the spreadsheet on the upper extremity, you're going to see shoulder muscles, extrinsic shoulder, and they're listed here. You'll want their origin and insertion, and it's a really good idea to list their function so that you know what they're doing. So the rhomboids, they're going to insert on the medial aspect of the scapula, and they're going to help draw the scapula back. So going through this is really the right way to learn this. It's not for me to sit here and tell you what each one of these do. Here's the compartments of the upper arm and also the forearm. Again, the major ones are going to be called out here, pectoralis major, the deltoid, etc. But I feel like I'm just repeating myself over and over again here, but you want to fill it in here. You want to know what the deltoid's doing, where the origin and insertion are, etc. Same story. Understanding what teres major is doing, the latissimus dorsi. On the rotator cuff, so the mnemonic for the four muscles that make up the rotator cuff sits, supraspinatus, infraspinatus, teres minor, and subscapularis. Remember, that's from the superior aspect and going posterior. So supraspinatus, infraspinatus, teres minor, and then subscapularis. And if you look at the Excel spreadsheet, they're listed here, but they're not in the order of sits, so you may want to correct that. And I would expect to be asked something about this order or about these muscles on the exam. So the muscles that act directly on the forearm, I think this was a little confusing for folks. There's actually only 3 muscles that work on the forearm. The rest of the muscles within the forearm actually work on the hand. Supinator, it does what it's called. It supinates the arm. And then the protonator teres and protonator quadratus, they're going to protonate the arm. And the quadratus is closer to the wrist or the carpal region, and teres is closer to the elbow. I know there's a lot in here, but the names kind of help you understand what they're doing. flexor carpi radialis. So learn the bold ones. Flexor carpi radialis is going to flex the carpal region. The palmaris longus, flexor carpi ulnaris. Remember, palmaris longus is one that not everyone has, and it actually doesn't go under the flexor retinaculum, which is what creates that that carpal tunnel. This is all anterior region of the wrist. So if you look at the Excel spreadsheet, anterior region of the forearm. So here you got anterior medial forearm, superficial group. This is going to be, again, these are all listed here. And then the posterior wrist, these are all going to be extensors, except for abductor pollicis longus, which is the only one that's not called an extensor. But the name tells you everything you need to know. It's an abductor of the thumb, and it's the long one. And if you remember, there was one hand muscle that I asked you to know, and that's abductor pollicis brevis, and we'll see that here in a couple slides. The carpal region, I would know that palmaris longus runs over the flexor retinaculum. It's the only tendon that runs superficial to flexor retinaculum, and then there's the 8 tendons that are within the carpal tunnel. And then again, the one muscle of the hand I asked you to know was abductor pollicis brevis, and you can, it's an accessory to what abductor pollicis longus is doing. All right, almost done. So lower extremity, again, you can divide things into compartments, which is what I would do. As far as the muscles acting on the hip and thigh, really understand that psoas kind of connects the lumbar region to the femur. This is a prominent landmark when you're doing radiological studies. The other side, the posterior side, the gluteus maximus is really the major player here, and then there's gluteus medius, and then minimus is under maximus. And then as far as the leg goes, so in the anterior compartment, you've got the quadriceps muscle, and it's 4 muscles: rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. Remember that rectus femoris is actually the superior or more superficial of the 4, so you will not see vastus intermedius if rectus femoris is there. Again, I put the compartments on here for some reason. And then looking at the hamstrings, remember that the hamstring is a group of 3 muscles, kind of like the quadriceps, and just know the names of the 3 that are in there. And again, if you look at the spreadsheet, you're going to see low extremity, posterior thigh, semitendinosus, biceps femoris, and semimembranosus. So you might edit this and say hamstring or something like that, right? To help you understand or remember. So the last part is the leg. There's 4 compartments in the leg. Most of these leg muscles are going to act on the foot. All the leg muscles in the anterior compartment are going to act on the foot. Just be sure you can understand the function of these. In the posterior compartment, the major player is actually soleus, but the one that you see is the gastrocs. It's a bad habit. I call them gastrocs. It's gastrocnemius. And these are going to form the Achilles tendon. So this is an aponeurosis of those 3 muscles. Plantaris is a small muscle that apparently isn't very useful, but for some reason I've always liked it. I don't know. And then another posterior compartment. So this is going to be the so if you look at the leg, this is going to be the posterior deep compartment, whereas the gastroc, soleus, and plantaris are superficial compartment. You've got tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And that's it for the review. I apologize that it's a lot to memorize, but um, part of anatomy is learning the structures, and we're going to go light on the origins and insertions, and fairly light on the functions, but just being able to identify is your goal at this point, or your major goal. So, good luck studying, and I will see you all on Friday.